Well, good afternoon, Mr. Chair and everyone. I'm Shen Yinan from the second affiliate hospital of Zhejiang University in China. Today, I want to present a nomogram for the postoperative pancreatic fistula. First, we have nothing to disclose. Here is the background. As a frequent complication in patients who have had pancreatic resection, the POPF rates always have been reported to range from 2% to 28%. This large range is mainly due to the different methods and the previously vague definition of POPF. So to address this, the RSGPS suggestion a POPF definition, which has been widely accepted since 2005, and this definition was recently updated by the RSGPS with clear and more precise statements based on the studies performed in the last decade. So in this study, we try to determine the risk factors for POPF after PD using the new definition, and to generate a nomogram based on these risk factors. About 220 patients who underwent PD in our center were included into the training cohort, and other 78 patients who underwent PD in our center in the different periods were included into the validation cohort. After multivariate analysis, we found that texture of the pancreas, size of the main pancreatic duct, tumor venous invasion, and the definitive pathology was the identified risk factors. So here is the nomogram based on the new definition and these risk factors. So this nomogram has a C-index of 0.793 and was internally validated. Our nomogram also performed better than the other most cited models in the validation cohort. So according to the nomogram, we identified 3 risk groups based on the risk distribution using the whole cohort, and specific management strategies were established according to the level of the risk. Clinical outcomes related to POPF also worsen in escalating fashion as points accumulate. Patients require more invasive interventions and suffer from more severe mobility with increased risk groups. Here is the conclusion. We create a nomogram to predict the development of POPF in patients who have had PD, and based on the new definition. But the reliability and the effectiveness of the predict model should be tested in more clinical trials. Thank you for your attention.
Okay, thank you, Dr. Shen. Dr. Shen, you have some comment? Someone in the audience have a comment? No?
Yeah, congratulations. Sorry. Congratulations.
Yes, excuse me.
Thank you for your presentation, but I have one question about the results of definitive pathology. And I think this couldn't be obtained or supposed pre-operatively. And I think if pancreatic fistula could only be predicted after the operation, I think the clinical outcome is relatively poor. How do you explain it?
Okay, that is a good question. I think that is a major limitation of our study. So I think we can use the frozen section to repeat the past oncological result. So we can get the predicted result immediately in this way, I think.
Okay, thank you very much.
Thank you.